My name is Joseph Valor, a PhD student at Columbia University School of Nursing. Today I'll be sharing with you our findings from our study titled Examining the Associations of Gender Minority Stressors with Sleep Health in Gender Minority Individuals. Gender minority individuals, which includes persons who have a gender identity that is different from their sex assigned at birth, are a health disparity population at high risk for poor sleep health. Minority stressors, defined as chronic forms of stress that are common and unique to stigmatized populations, are hypothesized as the predominant reasons for the health disparities observed in gender minority individuals. Stigma consciousness refers to one's anticipation of being stereotyped and rejected by others, and gender related discrimination includes unfair treatment during interpersonal interactions due to one's gender identity. There is evidence that experiences of discrimination are associated with poor sleep health, particularly among racial and ethnic minorities, but studies examining these associations among gender minority individuals are limited. The purpose of this study was to investigate the associations of gender minority stressors, including stigma consciousness and gender related discrimination, with sleep health in gender minority individuals. Participants included 279 gender minority participants from Project Affirm, a multi-site longitudinal study of transgender identity development, risk, and resilience. Using K-means longitudinal cluster analysis, we analyzed longitudinal data to create minority stress clusters that jointly accounted for stigma consciousness and gender-related discrimination exposure across 3 waves of data. Through structured questionnaires, stigma consciousness and gender-related discrimination were measured using valid and reliable instruments across all 3 waves. Sleep disturbance in the past 7 days were assessed at wave 3 using the 6-item promised sleep disturbance measure. And for sleep duration, participants were asked during the past month how many hours of actual sleep did you get each night at wave 3, which was dichotomized into short sleep duration, less than 7 hours, versus no short sleep duration. Figure 1 shows 6 established partition criteria used to determine the optimal number of clusters in the K-means longitudinal cluster analysis algorithm. Higher values on the y-axis reflect better performance for a given performance criteria. As you can see, the 3 cluster solution was chosen because it reflected the highest average performance. The 3 distinct minority stress clusters identified were persistently low stigma consciousness, low gender-related discrimination, persistently high stigma consciousness, low gender-related discrimination, and persistently high stigma consciousness, high gender-related discrimination. These clusters capture the persistence of stigma consciousness and gender-related discrimination in our sample. This suggests that participants with low stigma consciousness generally do not have high gender-related discrimination. Table 1 presents the sample characteristics. The final sample included 279 gender minority individuals with a mean age of 37 years, ranging from 18 to 89 years at wave 3, of which 46% were non-Latinx white, 23% identified as heterosexual, and 53 were transmasculine. The mean sleep disturbance score was 17, which ranged from 6 to 30, and 52% reported short sleep duration. Table 2 presents results of linear regression models examining the associations of minority stressors with sleep disturbance. We found that both the high stigma consciousness, low gender-related discrimination, and the high stigma consciousness, high gender-related discrimination clusters had significantly higher sleep disturbance scores relative to the low stigma consciousness, low gender-related discrimination cluster. Table 3 presents results of logistic regression models examining the associations of minority stressors with sleep duration. We found that participants in the high-high cluster were less likely to report short sleep duration relative to the low-low cluster. Our results show that participants with both high stigma consciousness and high gender-related discrimination had worse sleep health. These findings contribute to the limited evidence on social determinants of sleep health in gender-related individuals. Addressing minority stress in these individuals may be an important target for psychosocial behavioral interventions to promote sleep health. Furthermore, future longitudinal research is needed to examine factors that drive the link between minority stress and sleep health in gender minority individuals. Such work can inform the development of sleep health interventions tailored for this population.